Assalamu alaikum. So Mustafa was telling me if he wants, he can. If I want, he can introduce me. I was like, no, that's okay. I can introduce myself. Uh, okay. So I think we'll keep focusing on main things. Okay. Just the goal is gonna be for each of you to have the basic concepts. You have certain areas where you have some difficulty, and you'll do first EUS, then the second one we will pay more attention to you guys where we thought you had a difficulty before. Majority of the people, as many of you mentioned at D1, I have my way of doing it or my way of teaching it. Hopefully that would help. I'll show you that. D2, yeah, as Mustafa mentioned, majority of the people usually when they start doing it, they have a problem with the D2, and especially the scope movement from D2 backwards. Other thing is, just you have to have this concept, but the concepts should not be wrong. Just don't make up the things. But one thing really need to know, important thing need to know is that image shape or how it's gonna look like is gonna depend on the position of the transducer or the scope, and that constantly changes. Okay, when you're looking at from the stomach, and at that time the pancreas, you're looking at the way I have learned it myself is by reading the anatomy books, that atlas, Natter atlas, looking at the x-rays, and then sometimes even during a combined EUS CRCP case, just turn on the x-ray for a few seconds, see what the scope position is. I'll show some scope positioning and how it looks like, because when you're looking at the pancreas from the stomach, the way I imagine is like, okay, I'm looking at on top of it with the transducer sitting on the body. To take a look at the tail, I need to move my transducer this way. This is how I'm imagining, okay? And then go to tail further, okay, need to go to the neck, I'm going this way, okay? So this is like I'm looking from top, bottom down, okay? That's how I would imagine. So body is here, neck is, tail is here, neck is here. But this is like looking from the top, scope is straight in the stomach. When I go into the duodenal bulb, scope becomes long, right? And transducer goes up like that. So now I'm imagining from the duodenal bulb, I'm looking from bottom up. So the pancreas is gonna flip. So head is gonna go this way, neck is gonna be this way, body and tail. We'll show you all this as we move along. So what my point is, really based on what the position of your scope is, where your scope is, the imaging, positioning, and the shape is gonna change. So just keep that in mind. It's like, as Mustafa said, ERCP, very static. It's a dynamic procedure. In one place you are sitting, you're just gonna get that image. You're not gonna get any other image. So this is constantly moving around, but the movements are small. It's not like colonoscopy movements. It's a very layered, small movements. That's what you're gonna do. And other thing is, whatever you want to examine the area or wherever you want to focus, do your best to bring that between 5 and 7 o'clock position. Okay? But that's not going to work always. That's not going to happen always. But do your best to keep that in that between 5 and 7. That's how you're going to get the best image based on the same principle. Like with the ultrasonic goes way straight down, straight coming back up, going to give you the best image. If they are on the side, it's going to get scattered. And that's where going to be the artifact. So that's what's the main reason, goal is with that, to keeping that at 6 o'clock position basically. And Mustafa already mentioned, showed you the picture. So another concept about the camera is 2 centimeter behind the tip, okay? So if you are going through the pylorus, it's just like a ERCP scope. I always say that, and you probably heard that many times. Endoscope, camera in the front, looking front, moving forward. ERCP scope, side view, looking at the ceiling, moving forward. EUS, with the ceiling and the wall meets. So it's at 45 angle. On top of that, introducer or end of the scope is 2 centimeter beyond the camera. So if you are at the pylorus and you are looking at the nice pylorus completely, your end of your scope already got into the antrum and buried down there. So you're never going to get through the pylorus. So you have to pull the scope back few centimeter and then guide it through the pylorus. So that's the concept. D2, if you're looking at the ampulla, I will show that. If you're looking at the ampulla, you put your big wheel towards you, and that's the other term here I already mentioned about the way I'm going to use it. I think you use the same way too. Big wheel towards you, big wheel away from you. Same thing is with the small wheel towards you, small wheel away from you. So please pay attention to that when we say that, okay? Rotate the scope to the right means torquing the scope to the right. And that's going to happen just like ERCP scope with your wrist, with your shoulders, with your body movement. And it's these movements. Other thing is, the one who are taller among you, you can stand and hold the scope. There should not be a bend in the scope. Scope should be straight. It should not be like that when it's going through the mouth. So for the one who are shorter, step back from the patient to keep the scope straight. The goal is whatever you are doing with your hand at this handle of the scope or the wheels of the scope, whatever movement is happening needs to get transmitted all the way to tip. Goal is 1-to-1, as Mustafa showed in the video. If it's not getting transmitted 1-to-1, your scope is very uncomfortable. An uncomfortable scope is not a happy scope, okay? It's not like the other thing I usually say is, you need to be comfortable. You're going to get tense. So when we tell you relax, just relax. It's okay. Don't be anxious, okay? It's scope is, you are relaxed, scope will be relaxed. Scope is relaxed, you are relaxed, patient will be relaxed too. And most importantly, people sitting here watching you should not be nervous, more nervous than you are, okay? So just, you all are going to do just fine. Just relax, scope straight, and just pay attention to if we tell you to do something. Okay. So how much time we have? I already spoke like 10 minutes, right? Half an hour, take? Okay. So, and one other thing we'll do, I think we'll demonstrate a case too, like without the training. And we'll demonstrate 1 or 2 cases, one of us, just to show like what is expected, how to do the movements. So that way at least you know what we're talking about, okay? What time is it right now? Did you all keep going and so? Okay. History of US, I always tell about, like, I don't think I need to go through. Main thing is basically started in 80s, and at that time those old machines, our teacher tell us they were so bulky, and when you talk about that we're going to do EUS, there would be a silence of death in the room because nobody wanted to do that. And then it's like mostly in the beginning, even the users were trying to figure out what it looks like, what we're looking at, what are the wall layers and all that stuff. Basically, main breakthrough was when that linear scope was made. Radial scope, Mustafa already showed you. Radial scope, linear scope, radial, CT scan images, okay? And linear, this sagittal, right? Sagittal images, okay, like that. With the radial, you're doing just an imaging as does the CT scan, okay? So that's good, keeping in mind. For the radial, if you are looking at the pancreas, you're looking at the pancreas like that. To see the upper part and lower part, you have to move the scope in and out. On the other hand, when you're looking at the linear, you're cutting that right through this. So you have to move the scope right and left. That's what happens. So this is the first breakthrough FNA was performed in 1992 by Dr. Wellman in Denmark for a mediastinal mass or lymph node, and that's where it started, the biopsy. But main breakthrough was the interventionals, EUS, which came around 2005 or so. The diagnostic role, mostly with regard to the cancer staging, we don't use it much. CT scan is much better on it. The new CT scans, MRI, cross-sectional imaging, that does a lot better job nowadays, but mainly it's for diagnostic, means biopsy, and other is interventions, and then LAMS came and all that started. But mostly nowadays we use it not for the cancer staging unless it's a luminal cancer where it does help with the T2, T3, but mostly it's used for biopsy and interventions. So you saw some of those images, the old machines, but I won't go through that. So diagnostic, as mentioned, biopsy of the masses or the liver, and therapeutic, you already saw that. You saw those scopes. The scope in the middle is the for bronchoscopy, for the endobronchial ultrasound. So that's a much smaller scope as compared to the radial linear scope which you use. Mentioned about that a bit already. With the radial, you can do a FNA because when the needle comes out of the channel, it looks like a dot because the transducer is not looking at it straightly. And that's like a CT image. So that's why even though radial has a working channel, you can't do a FNA because you're not going to be seeing the needle through that. For the FNA or FNB, the needle needs to go in front of the transducer, and that's why we use a linear for that purpose. So these layers, I think I won't go through that. You already know that. And the terms we already, I think Mustafa mentioned about. What is it? But you talked about like how the fluid gonna look like, solid gonna look like. So I think it's important to know, based on the echogenicity, like anechoic mean basically there's no echogenicity. When it's too white like fat, it's hyperechogenic. And somewhere in the middle is going to be hypoechogenic, and fluid is anechoic as long as the blood is anechoic as long as it's flowing through the vessel. A clotted blood is going to be hyperechogenic. It's going to look white. It's not going to like, that's another thing with the fluid is, so keep that in mind. Masses, they are between hyper and anechoic, so they are not as black as the fluid looks like. And then hyperechoic or clotted blood, as I mentioned, air just scattered everything, really don't see that artifact there. And the fat and stone, looking at it, but then they give a shadow, which is black, obviously, but overall hyperechogenic. So these terms, you need to know and use them appropriately. Now, coming to performing US, how many do a station-based approach, like those who have done? So you start from station 1, you start from station 6, how you do it? Okay, you go all the way to the duodenum? Okay. So in the by the textbooks, there's only number 1 to 6 is 1 is the D3, 2 is D2, duodenal bulb is 3. So we're talking about the textbook stations right now. How many do by that? Yeah, so what I'm trying to get at is like those station approach, when they were doing the US, or teachers or mentors, they came up with these stations, but you don't have to follow those. So stations are basically the way I and I think all of us do is basically a organ-based approach. And for me personally, the way I do is I will start at the GE junction. The stomach is station 1, duodenal bulb is station 2, and then beyond duodenal bulb, second or third part of the duodenum. So that's how we do. And other way approach is, if especially in patients which are really not, they can't tolerate the anesthesia much or some instability, but you gotta do a EUS, in those cases, my station would be to answer the question, whatever that is. Do I need to take a look at the bile duct quickly if there's a stone or not because patient is septic? So then I won't be spending too much time in the stomach. I'll go straight to the bile duct, take a look at that. So that would be my approach to that patient. But if you have time and patient is stable, make this habit, do a complete EUS examination in every single patient. Even though you are doing it for a lump or a bump or a stone, but take a look at the pancreas, take a look at the bile duct, take a look at the GE junction, celiac axis, SMA, like do basically a complete EUS examination. And also liver, you can basically take a look at the whole liver. Maybe not a whole liver, at least a part of each of segment, all those 8 segments. And also the penetration of EUS, the best is up to 6 centimeter or so. Beyond that, really you get a lot of scattering and you may not be able to see anyway, and liver is so big. So you still, it's a kind of a solid enough organ. You can see majority of it, but sometimes it's out of reach of the ultrasound. So, but most of the time you can see the whole liver. This is the, and other thing is, when you're gonna get, you're doing, and sometimes, especially when you do first few hundred, you're gonna get lost. You go, they're not able to find a station or not able to, I should say, find your area of interest. Then come, spend a little bit time, see if you can find your way out. Just don't imagine it, just actually find your way out or not. If not, just come back to the area which is more familiar to you, be it a GE junction, be it a duodenal bulb, and start over from that. So no need to spend too much time in one area and just moving the scope right, left, have no idea what looking at it. And so don't waste time over there. And about the Doppler, we already talked about that, most of our did. So this is what I want to show you. These are few these cartoons that's going to show you, like this is a scope right here at the GE junction, right here, right? It's going to come down, it's a linear scope. I want you to take a look at it, how the scope moves and how the position of that transducer changes and how the different organs are being examined by that transducer. You see where that is? You move the scope, it's looking right here, these organs. You change the scope now, how many organs are coming in that view? So this is moving around. So that's like, let's imagine, this is what I was saying. I'm imagining myself looking from top bottom, okay? Just that's the imagination, okay? Now the scope is here in short scope position, straight, okay? Next one. So now scope coming down, more like in the long scope position, and in the duodenal bulb, and look how the change, like the transducer ultrasound scope is going to give you the image what's in front of it, right? And that's how it's going to get transmitted to the screen. So it's not like same direction all the time. That's what I'm trying to say. So every single time that this is going to change based on where the scope is and how you're moving it. So orientation is going to keep changing based on your scope position. Okay? And now it's going to go into the D2 and see, earlier it was looking at it, this from angle, so giving that view, now it goes down and looking it from the bottom up. So every time, again, changes the base. So you will need to imagine, need to memorize how that structures what you are looking at, how they are moving away from your transducer. That's how you're gonna, like really, that concept, when you get that, it will become easier. Because when you're looking at the pancreas from here, you're looking at your tail, as I said earlier, I mentioned, is to the right, neck is to the left, but when you are in the duodenal bulb, because you're looking from the other side now, so everything is going to flip. The image from the duodenal bulb is going to be, your head is there, like you see that stack sign, you see the portal vein, you see the pancreatic duct, bile duct, you move it towards your scope, towards the, rotate it to the right to go towards the papilla, right? And then rotate it to the left to go towards the liver hilum. So in that case, your pancreas is now like this. So your head comes here, uncinate is here, neck is here, body is here, tail is here from duodenal bulb. But from the stomach, what was happening, it was completely flipped the other way. So just get that concept. That would, once you get that imaging would make it much better for you. From the way I start is, again, we talked about that. For us, for me, the first station is GE junction. Right below that, celiac artery, SMA. That's my first station. So that's right below the diaphragm. Celiac artery, that's kind of a landmark for us because that helps us get to the pancreas. That's why we take a look at it. And also if any lymphadenopathy or for that celiac neurolysis, all that stuff. Celiac artery, how many branches it has? Which one? Okay. Who is the fourth one? No, no. That's a separate. That doesn't really come off the celiac, but 3 branches, right? Okay. What is the inferior phrenic artery? Like that's usually it's a trick question. First branch below the diaphragm. Okay, it's not a celiac; it's a phrenic artery. Okay, so what are the 3 branches? Anybody? Common hepatic. Okay, so need to know that because how they're gonna go left. When you follow the celiac, when you're examining at that, you follow the structure, whichever structure you're examining, you follow that with your transducer. Just make that habit. What's going to take to follow that? Is it pulling the scope back, moving it forward, rotating to the right or the left? Once you make that habit, it would become much easier how to follow that, okay? So left gastric, common hepatic, which goes down, splenic, you follow the splenic. When you follow the splenic, big wheel a little bit away from you, gently advance the scope, that will take you to the pancreas. Okay, so we'll show that, how that's gonna happen. Okay? And that's, many times, if I'm doing it myself, I may not do it right that way, I'll just go straight to the pancreas, I know how to get to the body, but for you, make it happen step by step and the proper way. That's how you really are going to learn. And all of you have seen the atlas, this image, right? Everybody has seen, right? At the anatomy and this image, okay? So on here, the stomach, pancreas is right behind that, right kidney, left kidney. Take this paper, if you have the atlas, take it out of the atlas, rip it off, okay? And then flip it over, okay? The top, which was on the top, comes to the bottom, right? That's your EUS anatomy, okay? This is like just one image, just take that out of the atlas and just see how that's kind of helping you. So this was up earlier. On the top, I just got the same image and just flipped it down. That gives you a US image. Okay. So now it's much easier. You're looking at it, body's here, neck is here, body here, tail here, left kidney, right? That's what you see on EUS. Okay. Adrenal is going to be here. So it becomes much easier when you have that imagination and take a look at it. Okay. Different stations. I think it would be much easier when we demonstrate that, from each station. So I won't go into the details. Main point was just really trying to tell, like in different positions, scopes. This one?
Station. Nice to see that you've got this is the three stations of the
Bronchitic head only. Yeah. So what we already talked about that. We don't have this like the book, textbook is like I asked them how many follow the station approach. If you follow the station approach, you should be going straight to that, by 1 to 6, you should be going straight to the D3 first and then following back. Nobody does that. So when they made the station, I think they numbered it wrong. That's one thing.
If you have the bulb as one characterized station and ancillary area and that as
Number,
the second
yeah, there is no need for third, sir. So it's just you can argue like in favor or against whatever you want, but basically bottom line is goal is to do a complete safe examination, get the job done, do it systematically, and that system is your own system, whatever works for you. Okay. But for sick patient, don't waste time. Go to what you need to do first, and if you still have time, patient is still stable, then do the rest. Okay, that's the main point. Okay. I think I'll just ask. I think I kind of got the message across on the what I was talking about, like different stations, different position. It's going to be different orientation, everything. Just the main goal is get this concept of orientation. It's going to change everywhere, wherever your scope is. That's I can't stress that enough. Okay, that's the only way to learn the US. Okay.
It's interesting because neither these stations have any clinical relevance in terms of interventions or diagnostics or stage anything, nor when it comes down to doing the DOP swarms, it hasn't actually translated that into a practice. So when we're doing these DOP swarms, it also doesn't sort of take into that as well. So, like all the experts say, but I have understood that make it simple when you're teaching. You have mediastinum, you have stomach, you have duodenum. Three places that you need to look at, and then you need to know what structures are you going to see in mediastinum, what structures you need to see in the stomach, and what structures you see in the duodenum. And that's a simplified thing, because for the longest time I was struggling finding the station 5, because you're actually spending a lot of time when you're actually learning, and then you realize that, at least I don't know what you Khalid and Mustafa feel about it, but you want to have. I feel that actually, as a trainee, when you simplify it, it becomes easier. Now you just need to know what you need to look at from the stomach, what you need to look at from the duodenum, and what you need to look at from the. And I think the mediastinum is the easiest, including the AP window. The way I don't know how you both do, but the way Khalid does it is very, very simple. The AP window is something that you struggle, although I don't know what the utility of that is with you respect. I mean, I find it very, very in tuberculosis patients. We've seen some occasional lymph nodes, but then those lymph nodes are also seen in the subcarina, which is much easier to actually. But because it's there, so it's important to just. But I think simplifying it easy, so,
I'll just comment. I think personally, the worst service to education of EUS was numbering of stations. Honestly, I think कई दफा होता है ना, it's like physicians back in the 50s and 60s were promoting smoking. I think teachers promoting station-based learning complicates learning for people. And the simplest approach you need to have is there are about 5 structures you have to understand and view, and you have to keep doing them over and over. Pancreas, bile duct / gallbladder, liver. You can look at lymph nodes in all these different areas, stomach and duodenum, and then anything extra. Beyond that, a linear upper exam, everything else is just a bonus. And if you think about it, my goal for this patient is to figure out how the pancreas looks, how the bile duct and gallbladder look, how the liver looks, how the lymph nodes look, and if there's anything else I find. That's all you have to do. Uske baad, it's all about, okay, where do I need to look from to see this part of the pancreas? And if you understand that from the second portion or the bulb, I see this part of the pancreas, that's all you need to know. My personal opinion and recommendation is forget these numbers. In my training, we never talked about these numbers. And my mentor, Dr. Mallory, who is very experienced, simply said, all you have to do is figure out these organs. So, masla ye hai, and I think there's especially an influence of people in education so focused on the stations that it keeps getting propagated. And then people keep getting confused. तो अपने ज़हनों को ना आज़ाद करें थोड़ा. Let them be free of these numbers and just learn what's in front of you in terms of the organs.
I think you all got that message very clearly from everybody.
आज
So,
के बाद मुझे numbers की ना कोई को बताए.
So if I can just add one thing, and that is, when you're starting, when you're looking at the normal bile duct or a normal pancreatic duct, it's not always easy to find it. And you start struggling, God, these guys see that all the time. I can't see the bile duct. But when the bile duct is abnormal or the pancreatic duct, pancreatic duct is a little tricky, but bile duct and stones in the bile duct are probably one of the easiest things easiest examination to do. But when you start focusing on a normal bile duct, that's when you say, oh God, I can tell you, I'll share my experience. I used to, whenever I was sent a patient with a possible stone, I used to say, oh, what if I miss the stone here? I'll be really ashamed. And then over a period of time, I realized, you can't miss a stone. If you know where the bile duct is, and if it's normal, if it's abnormal, it will come and hit you, literally. I think what I told them before you guys were here, is that when I started EUS, until I met actually Khalid, I thought, oh my God, this is not something that I can do. And then when as I learned, so I am sharing experience as I learned in a very different way, not in a program. And that's where I thought, what were my difficulties were stations and a normal examination. I think that is there's something that you need to keep in your mind.
yeah, so I think all of us have stressed it enough that don't pay attention to that numbers. Just remember what you're going to see from the stomach, you're going to see, which organ you're going to see from the duodenal bulb, what are you going to see from the second part of the duodenum, what are you going to see from the esophagus. That's one way to look at it. And then it's just basically an organ-based approach. So this is one of the videos, normal EUS examination. You'll see that I start right below the GE junction. That's the first thing I do, find the celiac artery. The way we will again demonstrate that, right below the GE junction, when you come in there, I know air, obviously the ultrasound doesn't like air, but in this one, as soon as you get there, just inflate the stomach a little bit to get an idea, make sure there's not a lot of fluid in there, patient is not intubated, there's not a lot of food and everything. Once you have insufflated it enough that you see the greater curvature of the stomach, take your EUS scope right there towards the greater curvature, like the opposite wall of the stomach. Once you get there, just suction all the air out. Okay, big V towards you is going to take you straight to the liver, left lobe of the liver. Okay, once you have that, pull the scope back to get 2/3 of the liver to the left side of the screen, 1/3 to the right. Okay, and then rotate. Your scope is going to be like this at that time, at 180 degree. Scope is straight. Okay, come back, and from there, rotate torque the scope to the right, bring it to the 90. That's going to take you to the aorta. Okay. Once you get the aorta in a landing position, it's a different way. Like when you're in the D2, it's going to be in this way, right? From here, aorta is going to be like that. Once you have that straight aorta, gently advance the scope until you find the celiac. Okay. You can follow each of those branches, but the goal is to follow the splenic. Sometimes your scope gets hung up because of hiatal hernia. In those cases, this approach may not work. You may have to release the wheel, go to the body of the mid-body of the stomach, and pull the scope back to take a look at the pancreas. But majority of the time, it's going to work. Release the wheel, gently advance the scope, follow the splenic artery, that will take you to the body of the pancreas. And once you are at the body of the pancreas, then the movement becomes easy. So this is what I'm going to demonstrate there. Okay. Okay. So going towards the opposite wall, what I mentioned, suction, you see the liver came up, and then once the liver comes up, from there, rotate the scope to the right, takes you straight to the aorta. Okay. You see the celiac, SMA, following the celiac, big wheel away from me, and gently advancing the scope takes me straight to the pancreas. Once I get to the pancreas, rotating it to the right takes you towards the distal body and the tail of the pancreas. You're going to see a kidney, left kidney at the bottom, right? You see that? And keep going. The tail of the pancreas is kind of stuck or kind of in between the spleen and the left kidney. So you have to basically see the spleen and the left kidney to be able to really see the whole tail, because it's going to be tucked in between those. Okay, so that's and then if you go to the left torque, do you see the duct is falling down around the portal confluence? That's going into the neck of the pancreas. I'll stop there for a second.
Paul, I don't know how obviously you were focusing on the video. I was focusing on Khalid's hand. And as he was explaining to you, he was consciously repeating those movements through his hands as well, showing what he would be doing. And I don't know that I wish we had that. We have the video, I'm sure.
Yeah.
It's important that your concept is so clear that just as you're showing a video when you don't see anything else, you're actually using your hands to tell what you need to do with this scope. And that obviously is what we all need to do.
So, Anya, I didn't even know like that happens. So portal vein, like your scope, when you're rotating it to the right, like then your duct is going down right there towards the neck. It's going around the portal vein and going into the neck of the pancreas. You see the confluence right there. In this case, right here, what is this? Which vein is that? And which vein is that? And which vein is that? And where is the liver? Right here. When you're in duodenal bulb, what happens? Where is the liver? See, get that. That will make it very easy for you to learn the US. Okay, orientation changes based on the scope position. Where is the bile duct here? Do you see it? Is this the bile duct? Could be, right? Yeah, I think it is. I'll have to honestly take a look at the video, but this could be a bile duct too, okay? So portal vein is going here. I think it is a bile duct. It's a little bit maybe a prominent. Uh, Portal vein going here, bile duct going here, liver is right here. This completely flips everything upside down. And here, when you're looking at it, portal vein is close to the transducer, bile duct is away from the transducer. When you're looking from the opposite side, bile duct comes closer to the transducer, portal vein goes away from the transducer. Everything flips, okay? So next station or whatever area you want to call is getting through the pylorus and going into the duodenal bulb, okay? Your scope is aligned with the pylorus, and a few centimeters before that, you are holding the scope like that, big wheel towards you. Sometimes what happens is it's at an angle. In those cases, if you are struggling getting into the pylorus because it's a little bit J-shaped stomach, sometimes happens, right? You can't get to the pylorus properly. In that case, start right at the lesser curvature, few centimeters before that, big wheel towards you and small wheel towards you. That's going to change the direction. The way Mustafa showed, the small wheel was moving the scope like that, right? Right and left. Big wheel up and down. But moving the small wheel towards you gets aligned the scope, moves the scope transducer in a way that it gets aligned with the pylorus, and it would become easier for you to get into the pylorus. Through the pylorus, into the duodenal bulb, make a stop there, okay? Again, even though EUS does not like the air, insufflate a little bit. What you're trying to look at is, because all of you had a problem with that station, so that's so insufflate, look at where the duodenum is going down, or what I call a duodenal apex, okay? Your goal is, your scope is gonna be like this. You go through that, scope comes right here, look at your duodenal apex. Your lens is going to be looking, your camera is going to be looking at the duodenal bulb towards the medial wall, to the left wall. Your goal is to put the transducer in left upper corner of the screen such that that transducer is in the duodenal apex. Camera is right looking at the bulb like that, okay? Put the transducer in the left upper corner there, okay? Big wheel towards you, suction all the air, move right and left. You will almost always find one of the three structures: portal vein, bile duct, or pancreatic duct, and from there you can follow the rest, okay? So this is what we're gonna do. Okay, going through the pylorus, stop there, looking is insufflated, looking at that left upper corner, will towards you, suction. If you don't see anything, rotate the scope right and left, okay? And then bile duct, make a habit. Usually first thing I do is either go to the liver hilum or go towards the papilla. For that, holding the scope, if I have to go to the liver hilum, I'll rotate it to the left. If I have to go to the papilla, rotate the scope to the right. Like this is the movement you're gonna do, okay? Sometimes, oh, it went through that. So that's the movement is gonna happen. You can follow the bile duct from the ampulla to the liver hilum by rotating right and left, okay? And if you feel like the papilla is running away, sometimes happens, pull the scope back a little bit, okay? And if like you may sometimes have to come back all the way to the pylorus with the camera, but your transducer is still gonna be in the duodenal bulb. So that happens, but majority of the time you don't have to do much. With the scope movements, you're gonna push it in or pull it or do the right or the left based on your goal is to keep whatever structure you are looking at it between 5 and 7 o'clock position. Once you make that habit, your hands and your brain coordination, just like driving, would get that, like without even thinking, you would know what you have to do with the scope to get to that structure or how to examine that structure. Once you are done with this, from here, you have seen the whole bile duct, you can see the gallbladder, cystic duct. From here, you can basically, if we do a liver exam, you can see the whole right lobe of the liver, and we might demonstrate that as well. In this video, I don't have that, but you can see that right lobe of the liver. And same thing is with the pancreas. When you're following the bile duct, pancreas is going to go away. Don't get distracted by that why it's moving away, because it's going to have to move away. Transducer needs to only look at the area what you are interested in. So if you're going to look for the pancreas, you have to follow the duct. From there, the duct is going to, from here is the papilla, bile duct went up like that, right? The pancreatic duct is going to go like that, okay? So you have to literally follow it like that, okay? And big wheel towards you, rotate it, and just sometimes in or out movement with the scope a little bit, not just to oppose to the wall. And your pancreas right now is, papilla is here, duct is coming like that through the neck, body is here, and tail is here. Okay, so you still may be able to, even from the duodenal bulb, you will be able to see the head uncinate is here. You rotate a little bit further from the ampulla, the uncinate you may be able to see from the duodenal bulb. Okay, so uncinate, head, rotate a left torque further, neck, you see the duct going like that into the body, and then pretty much all the way to the distal body sometimes you can see. So neck, we saw it from the stomach, right, up, and then we're seeing it from the duodenal bulb as well. And we see that from the second part of the duodenum too, because you're looking at the neck from different angles. So just keep in mind that to take a look at all of the whole neck, you should be able to see from all that stations, okay? So now you're from the duodenal bulb, we're going to go to the second part of the duodenum. There are two ways to do is the examination from the second part of the duodenum. Either you try to look endoscopically at the papilla and put your camera right on it. When you do that, your transducer is much distal, right? 2 centimeter. So you're not going to see the ampulla or bile duct, pancreatic duct. So what you need to do, once you put on there, pull the scope back, okay? And rotate right and left while you are doing. Goal is to find the aorta in this shape. It's going to come like that. That's an easy thing to find usually. That's what I'm saying. That's the goal, to find it. Okay? So once you find that, aorta is in this position. So from there, there are two structures. That's how I say aorta, being a big organ, arrogant, wants to be in the center. So there are two centers, two structures on the left, two on the right of that. Okay, two on the left are the IVC that's going to come, and then it's going to be the right kidney or segment 6 of the liver. Okay, one or the other. Okay, so either you see the kidney or liver, IVC, aorta. From there you rotate further to the right. This all happens in one position majority of the time. You don't have to move the scope. Once you have the aorta, don't have to move the scope. Maybe sometimes pull a little bit back to take a look at the pancreas, but majority of time you don't have to do that. And the only thing you are doing is right and left torque with the scope. That's pretty much it. Okay, pulling the scope back, aorta there, torque to the left. What are you going to see? Kidney, right kidney, or the liver, one or the other. Okay, from there, aorta, you rotate it to the right. Right torque, right there. Bile duct, further pancreatic duct. So those two on the right, other two on the left. And bile duct, pancreatic duct, first usually comes the bile duct, second comes the pancreatic duct. Once you have seen that, you still may not be seeing the papilla because you are compressing on it, either one thing, or it's still, you're still distal to it, even though you are able to see it, the pancreatic duct and bile duct. So you pull the scope a little bit further back and release the wheel enough that you don't fall back, but at the same time, you're not putting a pressure on the wall. So that will make papilla fall right in front of the transducer. Okay, so that's what you saw the papilla, bile duct, you can only see a portion of the bile duct. Once you have seen that, forget it. Done. Okay. Main thing is now the pancreatic duct. So from D2, you can literally see the whole pancreas by moving it back to the stomach with the scope in just one gentle motion. Okay. And majority of the time, again, you are able to do that. Sometimes you are not, but you should be able to see uncinate. You should be able to see the head, which you talked about, bile duct and the pancreatic duct, neck. Once you fall back into the stomach, body, tail, all this, you should be able to see that in that one motion. Okay, I'll show that in a second. And other thing is when you see at the bile duct and the pancreatic duct from that area, from D2, rotate that. You have an idea what the pancreas looks like, right? The organ, you're seeing that. Keep rotating your scope to the right until that either you see SMA and SMV or your pancreas disappears, because that's the only way to see the whole uncinate process. Otherwise, you will miss a part of it. Okay. You have not seen the uncinate process in this station completely until you see the mesenteric vessels. That's important. Okay. So make sure that you do that. And then from there, you just follow the duct, pancreatic duct back in there. So here, going into the D2, just try to find the aorta right there, right? And from there, rotate it to the right. First bile duct appeared, pancreatic duct appeared. From here, forget the bile duct, follow the pancreatic duct. And here, sometimes what happens, you saw the bile duct, pancreatic duct here, and then it's not coming in view completely. So forget about that because you already saw that, right? And now coming back slowly, fell out of the duodenum into the stomach, pancreas body there, coming towards the tail now. So that's like you usually can see the whole examination. Okay. For the mediastinum, very the way is like as Dr. Saad mentioned, like really what you're basically looking for the lymph nodes. But when you're coming back into the mediastinum, easy way to do is like if you have to find a small lymph node, what they tell you, paraesophageal, lower mediastinum, don't know exactly where that is. With the linear, what you can do is, I'll show that examination, like you start at the GE junction, celiac artery, rotate the scope from one side to the other side. You see the aorta, pull the scope back 1 centimeter, go back, see the aorta from the other side, means you have rotated and saw that. Pull the scope back 1 centimeter, go back. So that's how you do with the linear. Keep doing that. But to take a look at the subcrina, forget about everything. Don't see anything. Just pull the scope back to 30. That's it. In every single person, it's going to be between 29, 30. And you will see the left atrium. Once you see the left atrium, you rotate a scope a little bit to the right, right pulmonary artery, pull the scope back 1 centimeter, drop your scope, wheels facing patient, and then wheels facing down. That will take you to the aorta. Pull the scope back a little bit until the aortic arch comes into the center. Big wheel towards you, look up, that's your AP window. We'll show that. Okay. That becomes much easier.
One thing that, again, I think is important for us when you have a lean person, the images become much better. Okay, when you have a person who is BMI high,
How many? Do you want me to talk about this or leave it? Time क्या हुआ?
What you want in some people, so that's something that also has an impact. The early phase of your career, that's important.
Okay, that's what we don't need to do with that. Okay. So I have been told Dr. Saab is enlighten us on US tissue acquisition data.
30. Well, I'm happy for you.
No. I'm very happy for you to talk about that. I think we'll just leave it for now. Okay.
I hate to make any presentation.
I can talk about that. Okay. I think we'll.
Okay, so
Go ahead.
when you're done, just let me.
Yeah, I'm pretty much done.
Just tell you what's
yeah.
the plan.
Good. So this is gonna be repetition, repetition, repetition. That's how you're gonna get it. So gonna keep doing. We'll keep doing everything today. You will keep doing on your own, and you will get it eventually. So it's a repetition. That's what you have to do. Okay.
So we have the plan would be we have three rooms in the US in our setup. So we have an US room which is beautiful, um, 858, and there we can be celiac immunology, etc. All the therapeutic procedures are done in the fluoroscopy room. We have two fluoroscopy rooms, and both are equipped with EUS. So we don't have to shift our patients. So a lot of our patients have both procedures together, like in a lot of centers. So what I'm saying is that we have three rooms. One is purely EUS, where we do FNA, FNB, and celiac block, etc. But all the therapeutic EUSs take place in our fluoroscopy rooms. We have two fluoroscopy rooms. Both are equipped with the EUS. One has ME2 and the other one has ME3. And so in our routine work, it's, we do both the things together for a lot of patients as it is done elsewhere. And it saves the patient, even if we fail in ERCP, then if we have to do USBD, which alhamdulillah is pretty rare, we then don't have to shift the patient. We take consent for both procedures quite often if it's a difficult case or if it's a failed case being referred from anywhere else. So for you all, what will happen is we will have we'll have, three rooms. We'll be transmitting one and then changing as and when required. End of the day, all three rooms will be having exactly the same thing, because the aim here, and my faculty, international faculty, can add or if they wish, is to give you exposure to what Khalid has just shown time and again. The same thing to be repeated, the same movements to be repeated. The idea is not that you will be able to diagnose. The idea is that the concept of how you reach what you see in stomach, duodenum, or mediastinum, we need to just keep on hammering that, so that in the next 3 days, when you're doing, you're not worried about that so much. Then you can focus on what the abnormality is. If you know what normal is, then abnormal is not so difficult. Okay. And difficult cases, a lot of people struggle, and so it's okay. So three rooms we'll have all three international faculty will be with you. You will all get exposure to each one of them, and you will get to know some slight differences in approach, and then you can pick up the one that you think is most suited to you, or so that's what we're ready for. Okay. You're ready? Oh, okay. So we are going to do a demo case first. You've already seen a video, but we actually show you a live case. And then once you've had the demo case, then you go back and hopefully by the end of the day 3, the gray would mean what it means to you, inshallah. And how to get the right gray, or hopefully it should also be there. And then it's just a matter of practicing. You need to just keep doing it. Or if you're lucky, you have somebody with you who knows how to do it, that's even better.